Hi everyone, welcome. My name's Brittany. I've had this idea for a while of kind of combining two of my passions. So I'm a critical care nurse. I've worked in the ICU for about 9 years now, and I also love makeup. We have tons and tons of channels, right, about murder and mystery and makeup. Shout out to Bailey, she's the bomb. But I've always really thought it'd be kind of cool to combine those two and talk about different disease pathologies as I do my makeup. Pretty shy, introverted person by nature, but kind of a side story, if you will. My best friend of 13 years found out this week that she was diagnosed with IDC, which is invasive ductal carcinoma. So that is a form of breast cancer. And it just kind of opened both of our eyes, right? The life is short, and why not just jump out there and do something that you love? So I'm going to take a shot. I don't have too much to really talk about this episode other than just kind of giving you the background of what I think would be cool. And then hopefully as time goes on, you guys can give me ideas, different diseases that you would like to know more about, and I will look into that, and we can make a date of it. So like I said, no specific disease process to talk about today. Just kind of want to give you a little background, a little history of myself. I'm not being sponsored by any makeup brand or products, but I will link everything below. I'll try to give you as honest opinions as I can about different products that I use. And I subscribe to a couple of different makeup, monthly boxes. So I get tons of really cool stuff from those products that I probably never would have tried otherwise, that I'm then able to incorporate into my daily routine. So when I was, let's see here, taking myself back in time, I guess I was 17 and my mom had gotten remarried and was pregnant, and I got to witness the birth of my youngest sibling. We were in, myself and my three other siblings, as well as the new husband, were all in the room when my mom delivered, and I just was able to be kind of at the foot of the bed helping and watching as that process unfolded, and I just found it truly amazing. So it really inspired me to go into nursing school. Kind of did it the roundabout way. I was a first generation college graduate, so I wasn't really sure what I was getting myself into. I ended up doing biology as my first major, thinking potentially even pre-med, and then ultimately I just kind of fell back on nursing. That was what I wanted to do. I wanted to be a labor and delivery nurse. In that time, got married, had my first child, graduated with my degree in biology, and then the following quarter enrolled into an ADM program, which is an associate's degree for nursing. Like I said, kind of the roundabout way to do that. Throughout my nursing experience, which was absolutely fabulous, I found that I didn't like a thing about L&D. Found it just not my niche, right? We certainly need people in every single field of nursing, but L&D was just not for me. It was a lot of hurry up and wait, I'd like to say. Still a absolutely beautiful and miraculous process, but just not my gig. But I did find that I really loved two different arenas. I loved critical care and I loved the heart. So my husband and I at the time were actually in the process of relocating, so I ended up going into a PCU, which is a progressive care unit. For those of you who don't know what that means, that is basically a step-down unit from the ICU. So as they get a little bit less critical, a little bit more stable, they go to what's called a PCU. And that is where I started my nursing career. I was there for, about a year and a half. And then I felt like I was ready to take that next step and move into the ICU. So I transitioned over to our critical care, not a specialized unit. So a med-surg ICU, which is just really your kind of mixed bag, if you will. Anything from lung disease, heart disease, sepsis, which is when the infection creates a multi-organ dysfunction within your body, diabetic ketoacidosis requiring an insulin infusion, GI bleed, that's gastrointestinal bleeds. We take post TPA for a stroke, so that's a type of medication that we can give intravenously, which will go to the site of the clot and break that down. So really just kind of a mixed bag of everything. And I practice there. I've been in my same hospital for 9 years now, but 7 years in the ICU, and then I transitioned most recently into the educator role. So I am the educator for the critical care department. I've really found within this role, I've been able to truly expand on things that I had previously learned, but you get so busy in your day-to-day hustle and bustle of ICU life that you don't always get to really dive deep into some of not only the disease processes, but the different therapies, the different medications, the different equipment that we get to use. So that's just been really amazing to be able to dive deeper into that and then be able to provide clinical expertise to the staff that I support. Wow, the process of doing makeup is less than glamorous. I did also mention, even though I'm in a non-specialized unit, that I really love the heart. So for a short stint in my nursing career, I had transitioned over to one of our hospitals nearby and worked in a cardiovascular ICU or CVI. Unfortunately, I found that I was bored stiff. Shout out to the nurses who do it. It's truly amazing. They do take patients who would just have had valve replacements or come back from what we call CABG, which is coronary artery bypass grafting. So that's in layman terms, open heart surgery. And they get to do all of the recovery and care for those types of patients, which is truly amazing. But for me, coming from, I think, that mixed ICU, it was just the same patient type over and over and over, and I was bored out of my mind. So I, after 4 months, decided to go back to the ICU that I knew and love, and like I said, I've been supporting that hospital for 9 years now. Am I blended? But I still have not given up my love for cardiac disease, so that's where I've spent a lot of my focus. The hospital that I work for is smaller in terms of hospitals across the nation. We do have 2 cardiac cath labs, and we do see procedures for post-cardiac arrest, for post-heart attack. We place pacemakers. We offer intra-aortic balloon pump therapy for cardiogenic shock. That is a special device that gets threaded through the femoral, which is in your groin, up into the aorta and provides support for the heart as it heals and rests when it's in cardiogenic shock. I mentioned post-cardiac arrest care, so we do hypothermic management, which is maybe controversial, if you will. Not controversial, but just kind of dying out. Some physicians really support it. Others have kind of moved away from it, and we can certainly spend an entire episode talking about that. But fact of the matter is, it is still recommended in the American Heart Association's guidelines for post-cardiac arrest, so that is still the standard of care for patients who have had a cardiac arrest. And in my time as an educator, I've been able to really dive deep into management of those patients on intra-aortic balloon pumps. I've been able to dive into using pulmonary artery catheters that feed, again, either from a vein in your neck, we call the IJ or internal jugular, or they can do groin approach, which is that femoral vein, and they thread that catheter all the way up. It drops from the superior vena cava into the right atrium, threads through the right ventricle, and then into the pulmonary artery, and we can measure how the heart is doing, how the lungs are doing, and obtain a lot of pressures and indices based off of that catheter. Outside of a cardiovascular ICU or that CVI like I was talking about, it's really kind of been a dying trend, but we've seen with post-COVID patients have been coming back while they were admitted initially with COVID, and it was very lung heavy, right? They were having a lot of respiratory disease, respiratory pathologies. And a lot of those patients, especially in the first couple of waves, were really hemodynamically stable, meaning that their blood pressure and their heart rate was fairly stable. It was very, very specifically a lung disorder. And we're seeing a lot of those patients come back now with a lot of cardiac issues that they were not having when they had their initial lung injury. So with the kind of cycle of those patients, we are now seeing a lot more cardiogenic shock, myocardial instability, and the need to use pulmonary artery catheters and intra-aortic balloon pumps to manage them as they kind of go through this next wave of disease. Things that I certainly need to maybe be encouraged to branch out on would be endocrine disorders. I don't know a ton about cancer, as we don't really do a lot of cancer care, but I am certainly interested and willing to kind of broaden my horizon with that, especially as I mentioned, my best friend has been diagnosed with IDC. And as we explore different disease pathologies, I'm also going to be kind of giving updates on her process as well. And let me just say, so far it has been horrific. She's 34 years old. Her husband found a lump in her breast, and I did not actually know this, but a lot of women who present with lumps, are often found by a partner or a husband. So I just really commend partners and husbands for tender loving care. So anyways, like I said, 34, went in with complaints of a lump. They did a mammogram, followed by an ultrasound that did find that she had a 2.3 centimeter mass located behind her nipple. Referred her for a biopsy. The following Monday, went in for her biopsy. So with breast cancers, there is on the outer quadrant of your breast, it's called the tail of Spence. That's where most of breast cancers are actually found. And unfortunately for my girlfriend, her breast cancer is very central, very deep behind the nipple line. So when the physician was attempting to do the biopsy, he was having a really difficult time and had to keep threading the needle in and out in order to get it center to the lump so that he could take an appropriate biopsy. So very painful, lots of bleeding, lots of bruising. So bad, in fact, that the nurse afterwards pulled my friend aside and apologized and said that it's not usually that bad. We waited, as if it was me, right? We waited all day Tuesday. No call came with her diagnosis. It did come, however, early Wednesday morning. And the radiologist that called and gave her results was just awful. He was not, just no bedside manner, no compassion whatsoever. Told her the diagnosis, and she said, I have a lot of people who are going to want to know, so can you please just repeat the diagnosis for me one time? And he said, your breast coordinator will call you. Your breast coordinator will call you, and ended the phone call. Then she was told the following day to call the insurance herself to try to convince them to do the pre-auth quicker so that she could get a consult with her surgeon quicker, which, having worked in a doctor's office prior to working in the hospital and doing pre-auths all the time, never one time have we encouraged one of our patients to reach out and call the insurance company themselves. So she spent, upwards of an hour on the phone trying to get through to the right person to get her pre-auth approved faster, only to be told, I can't approve something I don't have a fax for. They had never even faxed over the request for the pre-authorization yet. So here she is, 34, 3 young children, trying to process the fact that she now has breast cancer, but has to sit there on hold for an insurance company doing somebody else's job, as far as I'm concerned, only to have that all have been a waste of time. So I'll get off my soapbox on that. But I just would like to say that the healthcare system is certainly not perfect, and it's an art, not a science, and we can always do better. And I am very disappointed that that was her experience. And if anyone else has had that experience, again, my condolences, because it shouldn't be that way. So yeah, I would just like to kind of spearhead not only what she's going through, maybe building upon that, learning more about IDC, and then also talking about disease processes that maybe you guys are interested in. Another thing that we've been doing in our hospital, and this has really, again, been exacerbated by the COVID pandemic, is CRRT, which stands for Continuous Renal Replacement Therapy. This is a specialized type of dialysis that's performed by the ICU nurses, or the critical care nurses, and in combination with increased cardiopathologies post-COVID, we also see a lot of AKI, or acute kidney injury. And unfortunately, I'm sure the staffing shortages for teachers and for nurses and healthcare providers in general across the nation are no secret to anybody. The dialysis providers have been non-existent at best, which has really put a strain on the hospitals. It's put a strain on the critical care. It's a huge problem for our patients because we have this increased length of stay, increased mortality, increased morbidity. So we were able to spearhead a program for CRRT. Hold on. We spearheaded a program for CRRT where we had to purchase machines, specialized machines that are able to do continuous renal replacement therapy, a process for training all of the ICU nurses, not only how to access dialysis lines, which is not something that we've routinely done and is new to our organization, to prime this machine, to hook up that machine to the patient, and then maintain the therapy in the machine while the patient receives the specialized therapy. And I will be the first to say that my team has gone above and beyond and has done truly a fabulous job with this. And I'm just so impressed. We've been able to initiate CRRT sooner. We've had better outcomes for our patients. And despite having this ongoing dialysis nurse shortage, we've been able to still provide this life-saving therapy to our patients. And I've learned a ton, not only about dialysis and pressures and kidneys and acute kidney injury, more so than I ever could have imagined. And I'm really thankful for that experience, even if it has been a detriment and challenging for my staff. My promise to you is that I will never do my eyeliner or my lashes on camera, because if you're looking for an expert on that, sis, ain't it? So for next episode, my thoughts are to kind of do a rhythm review. So talking about all of the different rhythms that our heart can go into, what causes them to go in that rhythm, what happens when we see abnormal rhythms, and maybe some of the therapies that we can use or medications that we can use to get patients out of rhythms that are not ideal. And that will kind of give us a really good basis to talk about any cardiac pathology in the future, because you really need to understand that. And to be completely honest, the number of nurses who can't identify even really basic rhythms bothers me. So I would really like to see an improvement on that. It is so essential to understanding most of what's going on with our patients, and we should be able to identify something else. I'd have just a normal sinus rhythm. So that'll be week 1, and then hopefully I have some comments, requests by then for what we can do on the next episode. Otherwise, it's going to be dealer's choice, and spoiler alert, I'm the dealer. And we'll probably do something else cardiac. But anyways, in the meantime, I hope that you've enjoyed this. I kind of am really just looking forward to seeing how this evolves, not involves, how this evolves. I'm excited to come up with a theme song and my little catchphrases, which I already know what my catchphrase is, but you guys didn't get to see it yet today. It's hard to talk when you do your lips. Oh, okay. So I will see you next episode, which I'm not sure when that will be, but we will figure it out. Have a great one, guys. Bye.